pretty loud. Yeah, it's so dark. Mic check. 1, 2, 3. Testing. Mic check. 1, 2, 3. Here I am giving a talk on ableism and its influence in healthcare settings. Just kidding.
Hey, that's plagiarism.
Just a little practice. All right, that's it. Here, I'll give this to you.
Sure.
And get that set.
And you'll tell me when it's live.
We are live right now.
They can hear me?
Yeah, they haven't started, but it's live.
Okay.
Just in preparation.
Okay. Perfect. Hello. Fancy seeing you here. Are you here for me? Oh, wow. Thank you. And free lunch. Can't beat that, right? I'm good. Yeah. What about you? Is Judy working from home today or out? Oh, okay. Oh, okay. All right, good. Just making sure she's okay. Gotta look out for our people. Okay. Hello. Are you gonna get lunch?
Yes.
Will you get me a veggie?
Just because, well, I'll let folks get something to eat. Why don't we do that? And we changed it around, just so you know. We moved it this way. We normally had it that way.
Oh.
But we moved it this way so people could come through that door.
Okay.
Instead of moving it. Because we had some folks needing to come through that door and they were looking at me and I was going, no, 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 get off, go around. So, yeah, we can't do that anymore. My face doesn't look like it doesn't do well with grimacing. Good morning, good morning, good morning. So I'm going to go ahead and get started. You all are grabbing some food. I'm Betty Dennis, and I'm the Director of the Diversity, Equity, and Inclusion Office for the College of Health and Human Services. I am so very pleased that you're here and you took the time to come and learn and learn and learn. And that's what this Lunch and Learn series is all about, is us learning and growing together so that particularly our students, as you move into the healthcare field, you are taking into account all of the patients that you'll deal with. I am pleased to introduce you all to our interim dean, Dr. Jennifer Harrison, and our associate dean, Dr. Ann Chaplow. So thank you both for taking the time out to come. And you all are welcome to hang around and stay and get to know folks as we go. But I want to introduce you to Dr. Gerlach-Houck, and she is from our Speech, Language, and Hearing Sciences Department. And she's going to talk to us today about ableism, and I'll allow her, or let her, not allow her, that's not the right word, let her introduce herself and tell you a lot more about herself. And then certainly, as she wants you to ask questions, she'll let you know how that will go too. So thank you for coming. Welcome.
Thank you. Hello, everyone. Thank you so much for coming and taking the time out of your day to be here, especially the students. I know you guys are in class a lot, so it means a lot that you're coming willing to listen to a talk. My name is Gerlach-Houck. I'm an assistant professor in speech, language, hearing sciences. And I'm really happy to be here today. I want to start just by thanking Dr. Dennis and the DEI committee for inviting me, and also for recognizing ableism as an important DEI topic, because it is one that often gets overlooked. So I'm really happy to be here and to share what I know with you. Let's see. My expertise, I'm a speech language pathologist. I have my PhD, but it's specifically in stuttering and communication stigma, or kind of mistreatment, which is a topic we're going to be talking about today. But for today's presentation, I'm going to be drawing from this book partly by Nario Redmond called Ableism: The Causes and Consequences of Disability Prejudice. It's free through WMU Library. So if you like this topic, there's an online version there. And I certainly learned a lot about ableism broadly from this book. I'll also be drawing from my knowledge of the lived experience of stuttering through my interactions with the stuttering community, as well as my own research on stuttering and some training that I've had from the National Institutes of Health and the National Science Foundation. In 2021, I attended a stigma research training method that was global, and I think there were 40 researchers from around the world who studied all types of sub-pockets of discrimination. And so that was really cool. I'll bring some of that in. And then also, I'm currently working on a project for the National Science Foundation that's focused on promoting accessibility for people with disabilities. And my project, in collaboration with MSU, is focused on making voice-activated technology accessible for people who stutter and other neurodivergent communicators. I may check my phone throughout this just to keep track of the time. I promise I'm totally present with you. If you have any questions, feel free to stop me, raise your hand, interrupt me at any time, and I'll also try to save some time for questions at the end as well. Yeah.
I'm your interpreter,
Oh,
and I'm going to make my way in front of you. And
please
over to your
do.
face.
Whatever you need. Thank you. Appreciate you being here. So I just want to say, this is broader than what I usually talk about, which is usually stuttering, very narrow. And so this is me going out on a limb a little bit, and it's a really cool opportunity for me to just think more broadly about ableism and what's relevant from an interdisciplinary perspective. I know we have OT, social work, nursing, public health, lots of different representation here. So I'll use a couple examples related to stuttering, but I want you to think about who you work with, the communities you work with, and what the applications might be to those specific communities. So before I start, I just want to do a little note about language. You'll hear me use both person-first language and identity-first language. So person-first language, examples of that, you tend to hear things like person with a disability, person who stutters, person with autism. Versus identity-first language, you hear disabled person, stutterer, autistic person. And you may notice the primary difference is how connected the person is to the disability status and these two ways of referring to people. Where in person-first language, when it was first introduced, the point was to intentionally create space between the person and the disability. To keep the focus on the person was the rationale for person-first language. And this was to avoid defining people by disability. I'll also just share that I'm happy to share my slides. So if you're taking notes or I go fast, I'll find a way to get them to you. Identity-first language actually came about almost in response to person-first language. Maybe, I don't know if you as students have ever heard or been encouraged to use person-first language. I see some of you are nodding. But some people prefer identity-first language. And one of the reasons why is because person-first language almost lies on the assumption that disability is a negative thing, that the person would not want to be attached to. Whereas if you integrate disability with who the person is, that feels more authentic for some people. For example, autistic people. Autism can affect a person's sensory experiences, the way they interact with others. It's woven into who they are for some people. And so some people don't feel like it's relevant to separate themselves from autism because they're so connected. Using identity-first language also creates space for disability to be something that's neutral or positive, for someone to take pride in the fact that they are a stutterer, rather than a person with a stutter. And this type of language is used in disability pride movements, so where groups try to reclaim their community, and again, kind of fight the status quo stereotype that stuttering is a bad thing. Stutterers can be the President of the United States. They can be anything they want to be. And so using this language is a way of kind of regaining power. You'll hear me use both types of language today because in the stuttering community, there's diversity and preference. And so I will alternate between the two. Person-first language is generally used by medical professionals or people talking about diagnoses. So I'm sure maybe in nursing it might be more relevant because you might be interacting more with disease than neurodivergent statuses like stuttering and autism that are so closely linked with identity. And identity-first language is usually used sometimes by self-advocates or people who are talking about an identity, stuttering as an identity, not an illness, not a disease, not a disorder, an identity. So before we get into ableism, I want to really get a better understanding of what disability is, because we could be having a totally different conversation if you and I have different understandings of what disability means. So I'm going to draw from two of the most common models of disability, the medical model of disability and the social model of disability, just to point out how discrepant our understandings of what disability means can be if we don't develop a shared understanding. So the medical model of disability is primarily used in healthcare settings. I don't know about your disciplines, but my discipline, speech pathology, heavily draws from the medical model of disability. And from this model, disability is viewed as a personal problem, something that is typically considered wrong with the person. So some type of atypical, you'll see me using quotes because I align more with the social model, some type of atypical functioning in the brain or body is the disability. The disability is rooted in the person from the medical model. Whereas from the social model of disability, disability arises from the environment, stigma, not being able to participate. From the social model perspective is an artifact of being excluded, having environments that are inaccessible. And so a classic example of the medical versus social model is thinking of someone who uses a wheelchair. So if someone who uses a wheelchair is trying to get in a building that doesn't have a ramp, from the medical model perspective, the problem would be whatever that person's impairment is. You know, some type of difference in the functioning of their legs maybe. But from the social model of disability, the problem is that the building is inaccessible and that the person can't get in. The building is only designed for some people. The building is exclusive. From the medical model of disability, lessening disability occurs when an individual seeks treatment through medical care from a professional, which introduces a hierarchy of a professional being the one who's in charge and being the one who's directing, compared to the person seeking treatment. Whereas the social model of disability would suggest that disability can be reduced through social action by reducing barriers, promoting inclusion, and by integrating rather than excluding people with disabilities in all facets of society. So from the medical model of disability, individuals are responsible to seek medical help. From this perspective, it's their responsibility to resolve their issue, would be what a medical model perspective would kind of communicate. The social model of disability, what I really like about it, in its strong form, some people who appeal to the social model may say the responsibility is solely on the environment. The person has no responsibility for reducing their experience with disability. But more contemporary social model theories can actually differentiate to where a person, the impairment itself can be disabling. People who stutter experience tension like that can be inherently discomfortable. And we don't want to discount that as impacting their quality of life. But that person can seek to improve their circumstances individually on their own terms, but also society has a role in improving circumstances for people who stutter. It's a collective responsibility. By society being more patient, not cutting people off, not laughing at them. You'll see lots of examples of microaggressions here today. And so this really allows for shared responsibility in improving circumstances for disabled people. So in general, from a medical model, individuals are expected to adapt, but from a social model, society is expected to change. So maybe you all are more familiar with the definition of disability provided by the World Health Organization. They draw from an ICF framework. The World Health Organization defines disability kind of using an umbrella term. I know this is overwhelming. I'll just talk you through what the point I'm trying to illustrate. They use an umbrella term to define disability that includes the impairment in body function or structure. So some type of difference in functioning. Again, for people who stutter, it would be a sensation of being stuck or losing control while speaking. So there is a bodily component. But disability also has personal factors that include behavioral reactions to that impairment. So some people who stutter react to feeling that loss of control by trying to hide stuttering. And you can probably relate to that disability broadly. Many disabled people try to hide or minimize their struggles because of the stigma that is associated with it. but also emotional and cognitive reactions of the experience of disability or the experience of stuttering. Activity limitations and participation restrictions. So how is the person able to interact with society? For people who stutter, things that are relevant, of course, are speaking with others. Also things like employment equity, educational equity. And lastly, and I would say in my work, I view most importantly, is the role of the environment in disability. The environment shapes how the person experiences all these subcomponents of disability. For example, people who stutter, when they're in an environment that's hostile toward them, rushing them, not being a patient listener, it actually makes the act of speaking harder. The environment influences the experience of stuttering. It, of course, influences how people who stutter feel about stuttering. And in a hostile environment, people can't participate. And so disability is very dynamic between the person's body and the environment they find themselves in. One term I want to introduce you to is the term minoritized. Maybe you haven't heard of it. I'm specifically using minoritized instead of minority. When we're talking about minority, we're talking about numbers. Whereas when we're talking about minoritized, we're talking about systems of oppression that usually apply to people who have fewer numbers that contribute to reduced power and inequity. So let me give you an example. My discipline, speech pathology, is 97, I believe, % women. Highly, highly skewed toward women in my discipline. So men are a minority in my discipline for sure. There are fewer of them if we're looking at the numbers. However, I would not necessarily say men are minoritized in my discipline to where they face systemic pressures that reduce their opportunity. And one of the reasons why I say that is because men are disproportionately represented in leadership positions in my field. The number increases significantly from 3% to I'm not sure what when it comes to how many men have PhDs in my discipline, how many men are chairs of departments. And so there's a difference between being a minority, which is very contextual. Are you a fewer number in a specific situation, and being minoritized, which is associated with facing systems of oppression. And maybe you didn't know, but disabled people are the largest minoritized group in the United States, with 56.7 million Americans and 1.3 billion people globally estimated to report currently having a disability. The number for Americans is based off census data. And so this is about 19% of the population, or 1 in 5 people. One of the things that makes disability, I think, often overlooked in DEI efforts is how it is categorized and who is considered disabled. Disability can be present at birth, thinking of conditions like Down syndrome or dwarfism or identities, or they can be acquired, like multiple sclerosis or brain injury. And disability has an open enrollment nature, which means that any of us could become disabled at any time. And given a 75-year life expectancy, the average person in the United States will experience 11 years with disability affecting their daily life participation. So this is something that many people experience. And because of this, or something that you could say we're vulnerable to if you view disability as something that's negative. Because of this, people have a particularly high fear of disability, which contributes to stigmatization of disabled people. I don't want to be that. Also, disagreement about what constitutes disability makes it difficult to protect disabled people. So stuttering is a good example of that. Many people who stutter, I've met thousands of people who stutter, don't know that stuttering can be considered a disability and they can get protections in the workplace because stuttering is specific to speaking, right? There are physical disabilities, sensory, mental. Does communication count? And lots of sub-communities have that same question. that makes them question if they're entitled to protections, and makes people in positions of power ask the same question. Are they deserving of the same civil right protections that other groups have? However, fortunately, disability is becoming a priority in health disparity research. This is kind of surprising to me, but it was actually just this September that the National Institute of Health designated people with disability as a population with health disparities. And when I show you the evidence about how significant these disparities are, it's mind-boggling that it took them until 2023 to add this as a kind of protected category. The reason why this is important is because NIH, funds a lot of research focused on health disparities. And if disability isn't considered a source of health disparity, that type of research isn't eligible for funding. So this is actually a really important step in promoting disability justice. Same thing with the National Science Foundation. They have a funding mechanism that my grant is through that's specifically focused on enhancing opportunities for people with disabilities. I can include a link. There are 16 funded teams in my mechanism doing really cool work. Like I said, mine's focused on making voice AI accessible for all communicators, but there are haptic backpacks for people with low vision that can send sensory signals to help them navigate their environments. And each of these teams has a short little video explaining their project. So I'd love to share that with you. But the point is, disability is becoming a priority in health disparity research, as it should. Okay. Any questions? I know I'm a speed demon. That's what my students say. Just put your hand up. I promise I'll stop. So what is ableism? That's really why you're here. You can't understand ableism without understanding disability. So that's why we started there. I like this definition. Ableism is beliefs and practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities, and often rests on the assumption that disabled people need to be fixed in one form or another. I think that's a good starting point. However, I like to pull in what Bodema and Butel offered, which is ableism is a systemic form of discrimination, meaning, in part, that it influences how we talk about and perceive disability, regardless of whether or not we are aware that ableism exists, or we hold views that disabled people are inferior to people without disabilities. So even if you're like, I know that ableism exists, I don't hold ableist views toward disabled people, you're still being impacted by ableism because it's so interwoven into our society, which I'll exemplify in just a minute. So here, again, ableism is systemic because it occurs at many different levels. It's not as simple as me saying something rude or me being mean or me excluding. It's much more big and complicated than that. The broadest level is cultural ableism. And I'm going to use stuttering as an example here. You can think about what's relevant to you. This is kind of tied to cultural norms. And in the United States, considering capitalism, there's a high value placed on efficiency, doing things quickly, getting things done, being productive. And if you're a person who takes longer to communicate, that's not a very accessible environment for you. That sets the stage that you got to get it out quickly or we're moving on. Structural levels of ableism are embedded again into our structures like the workforce. My prior research on stuttering has shown that people who stutter are less likely to be employed and are paid $7,000 less annually when they're in the exact same jobs with the exact same qualifications as people who do not stutter. So ableism influences hiring decisions, it influences our workplace experiences. Interpersonal, this is probably the level most of us think about. So micro and macro aggressions, the small ways and the large ways that people feel devalued because of the actions of others, which I'll give you some examples of. And the last layer is the personal level of ableism. This is kind of like self-stigma, if you've ever heard of this. But this is when people who are swimming in these waters about getting these messages, for example, about stuttering, begin to believe them as true. Begin to drink the Kool-Aid and think, okay, I see that people who stutter are represented as shy or nervous on TV, so that means that's how I need to be. I know that people who stutter don't get equal opportunity in the workplace, so I'm not going to try. And all of these levels are interconnected bidirectionally to where cultural, structural, and interpersonal stigma influences how people who stutter feel about themselves, but also vice versa. If a person who stutters has high levels of self-stigma and doesn't apply for jobs that they want, then employers don't become familiar with people who stutter. And it can perpetuate the idea that people who stutter aren't cut out for the workplace. And so it's a very complicated relationship between these levels. And just some example of microaggressions related to stuttering. I'm sure you can think of relationships to the communities you work with. This is a reactions to stuttering bingo that a stuttering activist made on her social media page. Their name is Stutterology. And they posted this and they had people who stutter see how many bingos they could get. And a playful way to point out all the microaggressions people who stutter experience. And it was shocking to see how many people who stutter had their boards covered. So microaggressions can be things like just breathe to people who stutter, saying just breathe, giving them unsolicited advice that if they weren't breathing, they probably wouldn't be living. People probably to think about breathing before when they're thinking about stuttering. You shouldn't have even told me. I'd never have noticed that. Just invalidate their experience. It might not seem like a big deal to you, but it might be a big deal to them. The person trying to finish their word but getting it wrong, like they're trying to introduce themselves, they're stuttering on their name like that, and the person's like, Nina, Ned, and they're like, no, just give me time to speak and I will say my name. So actions that rob people who stutter from the opportunity to communicate. You don't need to be nervous. Making assumptions that because a person stutters, they are also X, Y, Z, nervous, incapable, whatever other stereotypes are activated. Or it's so cute, especially women who stutter. So a form of patronization, that your stuttering is cute, which, again, a lot of people who do these things do them out of knee-jerk reactions. They're not necessarily doing them because they're bad people. They're doing them because they don't know what else to do in that moment. And so, microaggressions can take many forms, is the point. I just want to point out how ableism is reinforced within my discipline, speech-language pathology. And you can think about how your discipline might reinforce ableism. So using these same layers, in speech-language pathology, there's the cultural level of the dominance of the medical model. Our code of ethics, our curriculum, everything is set up to view speech and language disorders as inherent to the individual and in need of remediation. And so there's a whole cultural bubble that we're all operating in. Structurally, I think of the schools. I think of eligibility criteria, who gets school-based services. And in many states, kids have to stutter overtly a certain amount to get to qualify for school-based speech therapy. But we know that some kids who stutter, who are in the most pain, hide their stuttering, and so they're missed. And so the experience of stuttering is boiled down to what listeners can perceive, rather than what the person is experiencing, which results in lack of support. There's an interpersonal level between speech-language pathologists and clients. And it's not to blame speech-language pathologists. This is a larger consequence of the systems that we are working under. But SLPs often don't have a good understanding of stuttering, and they think the answer to stuttering is to stop stuttering. That is like telling a person with freckles to stop having freckles. It's rooted in their genetics and neurology. And the only thing, if I tell you to stop having freckles, you're probably going to respond to that by wearing makeup, by hiding your freckles, which is the same thing that we see with people who stutter when they are given strategies to try to sound fluent. It just encourages them to hide their stuttering, which, like autistic masking, is associated with poor mental health outcomes. And then finally, the person who stutters is in the middle of all of this, and the consequence is that some people adopt stuttering as a negative identity that they need to overcome. Of course they do, when they're in this broader context of what culture, the message culture is sending to them, the message speech-language pathology is sending to them. And again, all of these levels interact. I probably should have given the disclaimer, this isn't the most positive or optimistic talk. I'm trying to lay the groundwork for you to understand what ableism is and the problems of ableism. At the end, I'll talk a little bit about potential solutions, but I would be happy to send more resources if that's your main area of interest. So when I was doing this talk, I, of course, thought about the influence of ableism on patients or clients. But actually, the literature, when I went to go do some research, was largely focused on the influence of ableism on healthcare providers. And I thought that was really interesting with many students in the audience. So I'm going to draw a little bit from a systematic review of healthcare providers who experienced ableism by Lindsay et al., 2022. And this is a survey of like every interdisciplinary healthcare profession you can think of. They did a systematic review of PT's experience with ableism, OT, nursing, everybody who's in the room, I would guess. And they highlighted some examples of ableism in the workplace that disabled healthcare providers face, including students in training programs. And one is just this embedded assumption that healthcare providers do not have disabilities. Just the assumption from the get-go that everyone does things in a certified way, in the same way, without any additional support needed. And then the person has to navigate, well, do I disclose? Can I get accommodations? Is this a disability-friendly place? And when they're doing so, they tend to face bureaucracy and barriers to disclosing, getting the accommodation they need, sometimes even accessing disability services as a student. And in one study, 46% of registered nurses with physical or sensory disabilities experienced barriers where their employers failed to provide a reasonable accommodation. It's difficult to be a healthcare provider with a disability because of ableism. Another example was inaccessible, burdensome, or ineffective systems for reporting harassment and discrimination. So a healthcare provider experiences ableism at work, and then they have no effective way to report it to get anything done. Either the system is inaccessible to them because of their disability, or it's not effectively resolving the problem. Of course, the obvious is the inaccessible environment or barriers. Not having steps or stairs, no ramps, not having automatically opening doors, inaccessible meeting rooms that don't provide room for wheelchairs or whatever this person is bringing with them, bright lighting, inaccessible parking. And then interpersonal ableism. So this review of studies pointed out things like negative attitudes, stereotypes, stigma, bullying, rejection, retaliation, general hostility. These are the types of things that disabled healthcare providers may encounter in their workplace environment. And these lead to effects on their workplace experiences, where they may become hesitant to disclose their disability if they had a prior bad experience at work. They are recipients of disproportionate bullying and mistreatment. Disabled healthcare providers report more bullying and mistreatment than non-disabled, or people who do not report having disabilities. Lower levels of psychological health at work, maybe feeling vulnerable, angry, devalued, or helpless, and a negative career impact. So lower job satisfaction, limited career choices, issues with carrying out job responsibilities, and turnover, just like leaving. And I just want to make sure I'm sending the clear message that this is not necessarily because of their disability or the impairment they have. What tends to drive these effects is the ableism that accompanies that status of being a disabled person, which is why this is part of the DEI talk. I want to just give some examples of the influence of ableism on patients, hopefully to motivate you all to become more interested in ableism and anti-ableism advocacy. So this comes from a paper by Cron et al. In 2015, where they, again, did a review of studies that used big data sets, like national data sets, to compare disparities between disabled people and people who do not report being disabled. And I just want to point out, so here you'll see what the health indicator is. I can read it if you can't see it. You'll see the percentage of people with disabilities who reported that indicator and the percentage of people without disabilities who reported that indicator. I want to start with social determinants of health. So these are basically aspects of a person's environment that they find themselves in that have reliably shown to predict their health. Often things that we don't have a lot of control over. It's related to where you're born into. So people with disabilities are reporting to be higher levels of unemployment at all ages. And it becomes super discrepant after 16 years of age. In this study, 63% of people without disabilities were employed when they were over the age of 16 compared to 17%. And this has implications that go beyond employment, because what is tied to employment in this country is health insurance, which is what disabled people are in particular need of. So it is a big issue. People with disabilities were more likely to report having less than a high school education. More than half of people with disabilities in this study from 2010 did not have access to internet, had lower household incomes, and did not have access to adequate transportation. 1/3 of people sampled. And I am starting here because these social determinants of health are, again, how ableism is woven into our society, which leads to cascading effects that I'm going to point out, including adults with disabilities being more likely to report that they do not have sufficient social and emotional support. Differences in healthcare access. People with disabilities are more likely to say that in the past year they needed to see a doctor but didn't because of the cost. 1/4 of them in this sample. They're also less likely to keep up with routine screenings like mammograms and pap smear tests, again, because of the barriers they face to getting services. They may be more likely to cope in ways that are not helpful to their health, like smoking, or to not be able to engage in physical activity in their leisure time. And they're more susceptible to other, you could say disease processes, I guess, like diabetes or cardiovascular disease, and they're more likely to be victims of crime. And so the evidence about disparities, again, is pretty clear. Not that all disabled people experience these things, but that as a group, disabled people, largely because of the environment they live in, are vulnerable to health disparities, quality of life disparities. So just want to wrap up with some ideas for promoting disability justice. The first one is just a small one of my own, and the other are bigger picture ideas, which is why I was happy you're here from, what is it again? Public health. I feel like policy is the key to making change. If I, as a speech language pathologist, become less ableist, a better clinician, it doesn't matter if people who stutter can't get in the door to see me because of all the policy barriers, lack of insurance coverage, not being affordable, not having SLPs in more rural environments. And so I think policy is so key, but I will start with a clinical tip. which is considering the language we use. I just gave a talk at MSU, and this was just part of what I brought up, or part of what came up. Language is not inherently neutral, and it is not benign. Language, but Bodema Butel wrote, language use is constructive of social life. Through language, we make a case, take a particular stance, and produce identities. And I really like the part about produce identities as people who are hoping to help other people. The language we use sets the stage for how people come to understand themselves. So these are kind of relevant to my discipline. Maybe they're relevant to yours. People who stutter tend to start stuttering in preschool years. They come into CNSLP with their parents, obviously, and they get a report that has words like severity, at risk for continued stuttering, suffering, disorder, atypical, withdrawn. If I pulled out a sampling of SLP reports, you could just highlight these words that elicit fear and set a stage that stuttering is not going to lead to a good life for your child. And that is parents' first introduction to what it means to be a person who stutters. Or kids and adults and teens, they get evaluations as well. If they read their reports, that's their first introduction to what it means to be a person who stutters. This is not benign. We can use more neutral words, like instead of saying severity, and this will be discipline specific, maybe we can just talk about characteristics. Severity is kind of broad anyway. What does it mean to have highly severe stuttering? Do you stutter a lot? Do you hide your stuttering a lot? Is it tense? I don't know, because that word isn't helpful. Instead, describe the characteristics of stuttering. It's highly tense. The person reports a high level of fear talking with their classmates. Instead of talking about being at risk for stuttering, which is scary, we can talk about likelihood. They have an increased likelihood of stuttering because their dad stutters. It's just neutral. There's no fear or negativity, or maybe less fear or negativity embedded in that word. Instead of suffering, we can just say they're stuttering. It's up to them, well, in part, to decide if they're suffering. Who are we as healthcare professionals to make an assumption that someone is suffering with especially an identity that is just woven into who they are? And speaking of disorder, making space to call things identities. And again, this might not be as relevant to something like nursing, where it's really a disease process. That is part of an interesting debate in disability studies, is what's disease, what's disorder, what's identity, how do we decide? So it really depends on your discipline. Instead of talking about how a person is atypical and in what ways, we can talk about them being part of a larger community. Yes, stuttering doesn't happen frequently, but there's still 3 million Americans who stutter. And instead of saying, oh, you're the kid in your class who stutters, your brain is atypical compared to your peers, we can say, hey, you're part of a community of more than 3 million people who accomplish a lot of great things. And even words like describing how people cope with disability, they're withdrawn, they're anxious, they're this, that is kind of, this is a little strong, but I'll just say, almost like victim blaming, especially with people who stutter. Like, wouldn't you be a little anxious if people interrupted you whenever you tried to speak, or stared at you, or looked away from you, or mocked you? Isn't that a natural response to a hostile environment? And so we can describe people from withdrawn, but that's taking a side. That's not acknowledging why they're withdrawn. And instead, we could incorporate discussion of being excluded, especially if they report that, right? Because that's what can drive these, especially mental health disparities that can co-accompany things like stuttering and all types of other identities or neurodivergent statuses. So I really encourage you to reflect on the discourse that your discipline uses and have conversations and to make efforts to disrupt it. For people who stutter and other people to view their identity as neutral and to make their own meaning of what it means to stutter, rather than have that be dictated by practitioners, society. And this is last before we can turn it over to you all for questions if you have any. Cron et al. Pointed out some larger scale needs, which I think, again, is most important for reducing ableism. The obvious is increased access to healthcare and human services. Obviously, accessibility of healthcare buildings for people with physical and sensory disabilities, but insurance coverage is really a huge issue. And so, again, political change is needed, policy level. More and better data to drive policy and practice. So we need more resources for well-being focused disability resources. Historically, if you look at what has been funded by the National Institutes for Health in the area of disability, it is largely focused on biological causes and basic science that often, if you read the proposal, sets the stage for a cure. And this happens all the time with stuttering. I used to, when I was just, learning about ableism, think that that type of research was wrong. Like, I was like, that's wrong. I'm so against the idea of curing stuttering. What message does that send to the stuttering community? But as I've gotten to know the stuttering community, there are people who don't want to stutter and who would take a cure if there was one. So who am I as a person who doesn't stutter to say that type of research isn't welcome if part of the stuttering community would value it? So instead of saying, oh, that type of research is purely harmful, I've changed my view for the better to say that type of research has its time and place. So many people who stutter want to know what causes stuttering. They would sleep so much better if they knew why they did this thing every time they speak. But what we need more of is room for well-being focused research, room for research that focuses on reducing ableism and improving environmental conditions for people who stutter, which the NIH, NSF, other funding mechanisms are making space for. And more participatory research, which means more people with disabilities doing the research on their own community, rather than people like me, to some extent, who does not stutter, making inferences about what it's like to be a person who stutters. And I'm not saying there's no space for me as someone who doesn't have that identity in this field, but there's, again, systemic forces that have excluded people who stutter from doing stuttering research. And you can think about that for many communities. And then finally is strengthening diversity in the health and human service workforce. So increasing our efforts and being more successful at recruiting and retaining disabled healthcare providers, which is something I would love to think more at a college level. Do our students have exposure to disabled supervisors? They can relate to someone in a way, about something that's very important to them. And not just are we recruiting them, but are we retaining them? Or are we creating an environment that is not possible for disabled people to succeed in without a great cost to them? And also improving our curriculum to incorporate more than just the medical model of ableism, the social model, some of the things we've talked about today. So thank you so much. I have left time for questions. I really appreciate you coming here today, and I look forward to hearing from you if you have any questions. Thank you. Thank you. Yeah.
Many students in this college, and we have for years, and the university who have some sort of disability. And we have instructors do. I am often concerned about when you're looking for a job. Mm-hmm. And we brought that up in many ways, able place and social context. Mm-hmm. What are your ideas for resources to help our students be successful when they face these real barriers without the support that we might provide them through university? Mm-hmm. Or is there research on that? Maybe that's part of the new research that needs to be done.
Yeah. So I think I'll just try to summarize your question so people can hear it if they're tuning in. The question is kind of how does the way we support disabled students transfer or not transfer into their eventual work environments? So like, what do we need to be doing to support students in their training environments? And how is that aligning or not aligning with what they experience after graduation? And I definitely don't know about research on it. I couldn't synthesize the research on it. But I think advocacy is a big part of it. Helping students learn to advocate for themselves, coming from a place that doesn't view, that helps shape their view as their disability not being something bad. So in stuttering, for example, there's research on disclosure and how to more effectively disclose to listeners, but it's all about the listener. Everything's always about the listener. Like, what about the person who stutters? And in that literature, there's evidence that an apologetic statement, I'm sorry, I stutter, here's what I need, people don't get, it's not perceived well by listeners, but more importantly, they don't get what they need as often when they apologetically disclose. And so, honestly, I think one of the best things we can do is just help students and help our college develop a more holistic understanding of disability. If you're only starting from the place that disability is bad, of course you're not gonna be able to advocate for yourself well, because how could you? And so I think the culture, and again, these broader level things are what's most important, like recruitment, like retention, like who are our faculty, that type of thing. It's not a great answer, but it's what comes to mind. Yeah, thank you.
I'm in the field of blindness and vision, and
Yeah.
we experience this a lot. The numbers in blindness are that we graduate more people at the high school, college, and graduate level than any other disability area, that people with blind and vision impaired are still employed at less than 30%. Less than 30% are fully employed. And not only the point I want, your employment stuff is beautiful. Our thesis about that, we don't really know why. Our thesis about that, though, is people's belief that someone could possibly do that.
Yeah.
Right? Because you don't have the skills yourself to do it blind. You can't imagine that someone else could have those skills, right? And
Yeah.
so getting over that barrier, one of the things that we do is we have professors at the university who are blind and vision impaired. We have internship placements where the supervisors are blind and vision impaired, and we keep those people connected to our students, and our students connected to them, so they can see people who are blind and vision impaired doing the job well, getting the accommodations they need to actually be successful. I always call it not play second base. The other thing I think is really important to know as healthcare providers, though, is how often a healthcare provider has the capacity to impact a person with a disability's life in a way that could be destructive. So I walked into a NICU with a blind mom, and how are the nurses going to respond to that blind mom caring for those infants? And was the social worker immediately called in because they couldn't conceive of a blind mom taking care of two, 40-week-old babies, right? It is really an issue. So then the person with a disability has to show up more than 100%, right? To prove that they're not going to have those babies taken away from them.
Yeah.
And it is really for people in healthcare, in particular, to understand what a stressful moment that can be for a person with a disability. What if the person can't read the forms you're trying to have them sign, or can't hear well enough to understand what the instructions are? How do we take a moment to go, this person can get it, we can just get it to them a different way so that they can show their confidence and their ability. And it doesn't mean that we shouldn't be careful and that we should send 30-weekers home with somebody who can't take care of them well. But really, you will find yourself as practicing professionals in a place of having power in a way that the typically sighted person or the typically speaking person or hearing person doesn't have that same level of stress in that encounter.
Yeah, super important. We should talk more. We're very aligned. Appreciate your comments. Yeah.
Thanks so much for the fantastic presentation.
Oh, thank you.
I think, Jan, to your question earlier, I think one of the things that we can do structurally as a higher ed community is take a look at our essential functions and technical
Exactly.
standards. It's one thing
Yes.
that really limits enrollment, particularly with a lot of graduate students
Yeah.
barriers that we've arbitrarily put in place because we can't conceive of something other than ourselves.
Totally. I'm so glad you brought that up. And for students, what I think you're referencing is like essential functions of the job you're being trained for, competencies. So in language pathology, one of the tough things people, speech pathologists are probably like, man, she's just ripping on us. But it's critique, okay? We have to be open to critique. You basically are expected to be able to demonstrate perfect, as deemed by society, speech and language skills to become competent as a speech-language pathologist. I'll give you the example. I'm assuming most of you all haven't had any trouble understanding me today, except maybe my rate. I definitely go quickly and maybe some of my terms. But when I was in grad school, I was flagged by a professor for having a voice issue that they essentially funneled me into doing speech therapy for, and I went so far as to get a surgery to try to remediate with no hope. I still sound the exact way I sounded before. But the issue here is that our students who are going in certain fields expected to embody the perfect, every little standard of that field. Same thing for students who stutter. They have it way worse than I had it being in speech-language pathology, because in our document to become a speech-language pathologist, you have to demonstrate competencies and fluency, which is ableist, which is why I'm saying the bigger, the cultural, the structural levels are what's most important. Because we can teach people to be equitable, kind, but that's not going to matter if the systems they're in aren't not just facilitating their success, but not letting them thrive or even be successful at all. So, yeah, thank you. You're going to say something else?
I was just going to say that, I think it just really limits representation, and we all know representation matters.
Yeah.
So, touche.
Yeah, for sure. Yeah. Anybody else? You come for a question?
No, I'm gonna wait till you're done.
Okay, cool. I was going to say, I'm happy to share the stage, so please. Well, thank you. Oh, go ahead. Did you want to ask?
Yeah, so Dr. Gerlach-Houck, can you talk about the systematic review that was done, it was Krohn et al.?
Krohn et al., yeah.
Yeah, Krohn.
Anything specific about it?
Just wondering who the authors were.
It's Krohn et al. 2015. I can send it out. Yes, but it was a systematic review of population differences between people with and without disability on various indicators using big data. Yeah, I can send it to you. I will get these slides with resources available to Dr. Dennis. So
thank you. Thank you all for coming. We are so appreciative that you're here today. Let me turn. Okay, there we go. There is a form that we came up with to give you some information about ableism, and so feel free to take that. It's over here. You can certainly use the DEI Dropbox to submit your thoughts, experiences, your thoughts about this workshop if you want. You are certainly welcome to use that Dropbox for that. And I want to, that's why Charles came up. Charles is our the graduate assistant for the DEI office, and he's always looking for other students who are interested in working with him on a subcommittee. So I'll give him a few seconds as well to say something, but I do want you to give a big hand clap for Dr. Gerlach-Houck and thank you so much for providing me. Did you want to say something?
Yeah, so like Dr. Dennis said, I'm Carl, and I'm representing the student DEI body for the CHHS. And if there are experiences that you have and would like to share with me, I would like to sit and talk with you about them. And make sure your voice gets heard. So I'll start having office hours. Personally or exclusively, and after this, I'll be kind of standing by the fact that you want to have anything that they wanted to mention. So just wanted to introduce myself and say thank you for coming to the meeting.
There's still left, still
Thank you. Thank you so much.
And yeah, give her a gift.
Thank you. That is so sweet of you. I'm happy to be here.